And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done at this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of Medi classes 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis. This is the investigations required. This is the likely treatment. And then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken. You will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases in which a lot of interactive discussion.
Yes, Belting and West, who discovered insulin in 1921. So it is approximately 100 years back. So before that, all the patients were left in a ward called death ward, and they were allowed to die. So after that, this is the dog over which they tried the insulin, and now we have battery of insulins which are making diabetes possible. So I think we have many from the institutes or government institutes. What insulins are you using? I mean, Lispro, Aspart, Glargine. Yeah, Epitra. Any other? Apart from this, anybody using mixed insulin? You are using. Okay, fine. And any other insulin or brand name or any other thing you remember? Okay, fine. So we'll be discussing a few more newer insulins that has been approved and some are under trial for approval. So we know that insulin is a peptide hormone which is produced from the beta cells of the pancreas, which is situated below the stomach. And these beta cells has a specific sensor called glucokinase. And even blood glucose reaches the blood, there is a pathway called incretin pathway. So this pathway stimulates the pancreas to release insulin even before glucose reaches to the blood. So insulin is present there in the blood before even glucose reaches to the blood. That's why this insulin acts rapidly. Whenever we eat something, insulin is already there. And after that, by measuring glucose, again more insulin is released. So insulin is a complex hormone which has been preformed and stored and synthesized even before the food comes. That's why this insulin is quick. And this is the reason why our blood glucose is so tightly controlled, because blood glucose is measured minute to minute, and according to that, insulin is released so fast. And this is the reason why we need more and more insulin, because right now, whatever we have available, they are not that either fast, they are not the long acting. So this is the normal insulin secretion in our body. So we know that we all eat meals and all meals have carbohydrates. Even if we eat green vegetables, they have some carbohydrate. So we need insulin at each meal, right? But apart from them, whenever we sleep for 8 to 10 hours, we have hepatic glycogenolysis. So liver will start producing glucose, and that's why we don't experience hypoglycemia during night. The normal healthy people I'm talking about. So even to suppress this hepatic glycogenolysis, we need insulin. So all 24 hours, we will have some insulin in our blood and in our body. And this is all we should replicate whenever we treat the patient of type 1 diabetes. Why? Because they don't produce insulin at all. So we need to give them insulin to suppress this hepatic glycogenolysis as well as to cover their meals. And that's why basal bolus regimen is the standard care. When I was in PG, we were using mixed start 30-70, 2/3, 1/3, right? That was the standard practice. But nowadays, when some of the stalwarts of the pediatric endocrinology say that to use a mixed start or mixed insulin in a patient, in a kid with type 1 diabetes is a crime. Why? Because if you use mixed start, the child has to eat according to the insulin, because there will be fixed amount of insulin which will be there. So if you use basal bolus, the child has to take insulin according to the food. So we know that the child might eat large meal, they don't even eat at all. So basal bolus is the thing. We give fixed basal at fixed time of the day, that will act probably for 24 to 26 hours. And we give bolus whenever child wants to eat. So this is the reason why basal bolus is the treatment of choice. And what do we all have till now? Regular insulin. Of course, we know that this is the human origin, genetically bioengineered insulin, which has got chemical composition same as our normal insulin produced by the pancreas. So this can be given as IV as well. But the regular insulin has limitations. Like we all know that regular insulin start acting by 30 minutes after injection. It will have its peak at around 3 years of injection, and it will there in our body for next 6 to 7 hours. Next, so to overcome this benefits, we develop rapid acting analogues, right? So what do rapid acting analogues? All Lispro, Aspart, and glulisine all are called as rapid acting analogues. They have some change in their composition so that they are working rapidly. So their onset of action came from 30 minutes to say 15-20 minutes, and they will have peak at 1 hour. Exactly at that time, the glucose from our food is highest, and they will excrete it by 4 to 5 hours of the day. So rapid acting analogs definitely is an upgrade from the regular insulin as far as the bolus is concerned. But now what about the basal level? So for basal we have NPH. It is called detimir or NPH. They can act for 12 hours, but still they have a peak at 6 hours. So after giving NPH, if at all you are giving 2 NPH, that is available in many government institutes, you should ask the child to eat something at 6 hours of that NPH. Otherwise, child will have hypoglycemia. So this is again a limitation of NPH. So again an upgrade came, say in 1990s in form of glargine. So what is glargine? It is a long-acting insulin which nearly mimics the basal insulin secretion. It starts acting by 1 to 2 hours of the injection, and its effect will last for next 20 to 24 hours. It is got very low peak, so there are very less chance of hypoglycemia, plus a single day injection is suffice. So this is all what we have till today, but still, why we need further improvement? What are the drawbacks? Can anybody tell what are the drawbacks of all that hypoglycemia risk? Okay, as I discussed earlier, with NPH as well as regular insulin, there is a hypoglycemia risk. If the child is not eaten properly after giving regular insulin, child might experience hypoglycemia at 4 to 5 hours of the injection. Same as with NPH at 6 to 7 hours of the injection. Late in the onset of action with regular as well as rapid acting analogues. So these all need few minutes to get into the blood and have their actions. So definitely there is a lag in action, and while because we know that our childs are kind of a cranky, mujhe kuch do, right? So there are many instances in which child is not ready to hold for say 20-30 minutes after giving the injection. Child will be demanding that I need food. So definitely we need improvement as far as the onset of the action is concerned. Then duration of action. NPH we have to give 2 shots. Now if I talk about glargine, if the requirement is in high dose, say maybe somebody is requiring glargine at 30 or 40 units a day, then they have experiencing their action to be finished at around 20 to 22 hours of injections. So they might have elevated glucose after 20 hours of injection. So in older child or adolescent, this may need 2 doses of glargine as well. We have many patients when we require 2 doses of glargine. So again, we need a further long-acting insulin. Post-meal shot is not possible with any of our available insulin. Many times it happens that we don't know how the child will eat, how much he will eat. So if there is any insulin which we can give soon after food, that will be definitely beneficial for the kids as well as the parents, because otherwise mother is fearing that if I give 3 units of regular insulin and the child is not eating, what will I do? Many times what kids do that they want to eat sugary things. So after his or her mother gives the shot, they will deny that no, I will not eat the food, because they know that now my sugar will be down, my mother will be anxious and she will give me chocolate. I have 3 to 4 patients. This is a real experience. So again, if at all any insulin can be given post-meal, that will be again the benefit. And daytime variability. So glargine is a long-acting. There has been a notification of the fluctuation in the concentration during that 20 hours as well. So these all are problems with the regular or rapid acting or a long acting insulin. So what do we need? We need a faster acting insulin, even faster than rapid acting analogs. We need a longer acting insulin, even longer than glargine, and we need a stable concentration. So if we can change the insulin molecule so that it become faster or it become longer, then definitely we will have good time in range. So nowadays the concept is time in range as compared to the HbA1c. Ideally 50 to 60% of the time child should be in the TIR, that is maybe 80 to 140, 80 to 160, so that the long-term complications, either macro or microvascular, can be prevented. So nowadays ultra rapid acting analogs have been developed, and first is PIAS, that is fast aspart. Many of you have heard that PIAS is officially now approved by the International Society for Pediatric and Adolescent Diabetes. So what they have done, they have added arginine and niacin to the normal aspart. so that it gets quickly into the blood, and its onset of action is very faster even the normal aspart. So we can see that it starts acting within 5 to 10 minutes of injection. So again, this is good for the kid who demands this food soon after the shot. So again, it has got action onset of action at 0.1, that is 6 minutes, so 6 to 12 minutes. It has peak action at 1 to 3, and again it has the same duration of action as compared to the rapid acting analogues. So it is very beneficial as compared to our normal rapid acting analogues. And also, if I want to talk about the cost of PRs is even lesser than some of the rapid acting analogues. So definitely, this is way better as compared to the normal rapid acting analogues, and it has been approved by the FDA for use about 2 years of age. So Fiasp is definitely worth using it nowadays, and there is very low chance of hypoglycemia as far as the Fiasp is concerned. Second is Lispro. We have ultra rapid acting Lispro, which is called URLI. It has been started using in Belgium and all, and there are few adult studies related to the ultra rapid acting Lispro, and they have added these two molecules of citrate and treprostinil, so that the Lispro has been made as rapid acting. So again, this is a comparison with the normal Lispro. It starts action early, 5 to 10 minutes. It has got better sustained peak, and again it has got action up to 5 to 6 hours. So definitely it is better than Lispro, but still it is under trial. So it has been not approved in the kids. But many studies, and this is from the Japan, they have found that it has got accelerated insulin absorption with a reduction and in late exposure. So again, this is beneficial because it acts fast and it gets excreted quickly, so that there are low hypoglycemia as compared to the normal Lispro. But again, this is not approved in the kids, but it will be soon available once the approval is there. Now coming to the long acting. So long acting started from 1946. The NPH was first discovered in 1946. Then glargine came way back in 1992. But again, they felt that glargine is not enough. So they have started detimir, which is there in 1996. But again, detimir is having peak, and also you need 2 doses of detimir. That is same as NPH, more or less. So then research were going on by changing the few amino acids in the insulin molecule, and then they come out with the digludec, that is in 2010. So we'll be talking about digludec and glargine 300, because these two are the long acting which has been approved and which can be used in pediatric population as well. So digludec we call it ultra long acting insulin. So at the position of B29, it is conjugated to hexadeconic acid with lysine. So what does it do? It will form hexamers below the skin. So that's why it will be very slowly released in the blood, and that's why the half-life is more than 20 hours. So most important is the action, longer action. And this is a comparison. This is our normal glargine, which has got some peaks, but this has got sustained concentration all over 24 hours. So even if mother has a delay of giving long-acting insulin by 2-3 hours, we don't have to worry if we using digludec. So digludec is available as Tresiba in the brand name, and these are the official recommendations. It has been officially approved by APES and FDA. It is virtually peakless insulin. I think it is not visible. Single daily dose is enough even in bigger kids or those kids who are weighing above 60 kg, and it has been approved above 1 year of age by FDA as well. So again, if we compare glargine with digludec, the cost is 3 times. So definitely cost is a major factor as far as the endocrinologist practice is concerned, because we are prevented by this cost issue. But still, those who are requiring high doses, those who have Lentus dose, which is a glargine dose, which is not enough, then definitely digludec is the insulin, because it is far better pharmacokinetics as compared to glargine. Second is glargine 300. Now, what is this? This is the same glargine but concentrated glargine. So this is glargine 300 means 1 ml of insulin contains 300 units of glargine, while that normal glargine is 1 ml contains 100 units. So this is 3 times concentrated. So just by making concentrated, they were able to delay the absorption And again, this is the same as degludec in as far as the pharmacokinetics is concerned. So again, as compared to our normal glargine, it is virtually peakless. It can act about 24 hours as well. And this is also approved. So it starts by action early by half to 1.5 hours. It has got minimal peak and it has got half-life of more than 42 hours. So if at all there is a delay for say 3 to 4 hours, if you are using glargine 300, it is fine. So again, this is an ultra long acting with peakless effect, minimal hypoglycemia because there is no peak and once daily dose is fine. But again, cost is the issue as compared to the normal glargine. Again, it is 2.5 times, 2.5 to maybe 3 times costly. But still, this all insulin will be available in the low price in the upcoming years. And looking at to the hypoglycemia management and low hypoglycemia, if we can prevent just one admission of hypoglycemia, the all costs can be recovered. So definitely, it is worth trying in those patients who can afford the either degludec or glargine 300. But it is approved above 6 years of age by the ISPET and FDA. And this is the study where they compared glargine 100 to 300 as far as the nocturnal hypoglycemia is concerned, and they have found that the event of nocturnal hypoglycemia, which we fear the most as an endocrinologist, was very low, 4 events per participant year as compared to 9 of. So it almost reduced twice as the nocturnal hypoglycemia is concerned. So again, this is a comparison because glargine 300 came later than the degludec. They have again, this is an in-range study, which is a first randomized controlled trial. They have compared directly glargine 300 with the degludec, and they have found that this glargine 300 was non-inferior. Non-inferior means it was similar in reducing the HbA1c from 8.5 to 7.5, and nocturnal hypoglycemia and glucose variability all will have similar effect. So these both ultra long-acting insulins are way better than our glargine as far as the hypoglycemia is concerned, as far as the stable concentration of the insulin throughout the 24 hours is concerned, and glucose variability is concerned. So newer insulins provide flexibility because if you use glargine, you have to tell parents that this should be given at the exact time. If you delay, then there will be a lag phase of insulin free in the blood. They have more time in range, of course, less glucose variability. They have less chance of hypoglycemia, which we fear most, but cost to be considered because these all are right now costlier, say maybe 1.5 to 2 times as compared to our normal insulin. But still, these are the way forward as far as the newer generation insulin is concerned. So with this, I would like to end my talk and I would like to thank you all again for patient listening. Thank you.
So I think it was very nicely summarized by Chetan that we are talking about longer than longer and shorter than shorter. That's the aim. So Dr. Agrawal, what is your thoughts about the question?
Yes, it's really enlightening to know about the various insulins which are available and making the insulin suit to the needs of the patient. That is more important for the lifestyle, especially in children, rather than your insulin and then the child is advised accordingly. So this is very important to prevent hypoglycemia and quality of life. That is a variable which is very important, especially in pediatric type 1 diabetics, because quality of life has to be there rather than compromising with this, and that is possible with the newer insulins if used with wisdom like Dr. Chetan's. Thank you.
Dr. Ganguly?
Yeah, sure. Congratulate you on a very eloquent talk. You have beautifully summed up the advantages of the analogues and the next gen insulins. You're right. As far as efficacy is concerned, probably there's nothing to do between the human insulins and the analogues. But yes, when it comes to the safety parameter, hypoglycemia, and the flexibility, there's nothing to beat it. And very correctly put, cost is the value. That's it.
Dr. Chetan, is there any effect of inhaled insulin?
Sorry?
Inhaled.
There is no effect of inhaled insulin.
Yeah, right now at the Cleveland Center and few centers in USA, there is a trial going on for the pediatric inhaled insulin. When I was there, the trial was started by Dr. Jamie Good. They are using in adults. The adult approval is there, so they are using as a bolus insulin in the adults. But still, pediatric trials and pediatric results are awaited. It is called APES, and maybe soon we will have inhaled insulin available within the next 12 to 18 months. But again, still it is under trial.
The problem with dose is high and it comes in a multiple quantums of dose. You can't give 0.5, 1, you have to give 4 unit, 8 unit, 12 unit. So it's not going to be as easy in terms of that. So probably the way forward is more towards the pump way rather than the inhaled way. That will be the way forward because inhaled insulin came and was already lost once. We all know what happened to Exubera. And now Afrezza also what is happening is that we are giving 4 unit, 8 unit, 12 unit. So how many children will require 12 unit equivalent and then reliability, delivery, all those issues will be there. So I will be skeptical. I don't think it will take. The only way inhaled insulin has been used is prevention of diabetes. And there also it has not been found to be successful in that. So I think thanks Chetan for this wonderful session, Dr. Alika.
We can use it in Rhizobag and make that. Is it physically?
See, Rhizobag contains what? Bajpai and the short acting, right? So we need to fix those combinations. In children, what we want that we should be given 3 doses because we want to decide the dose by looking to the pre-meal sugar level. So that is not possible with the Rhizobag. So if at all you want to increase your short acting and you increase the Rhizobag dose, what will happen? The dose of long acting will also increase. So it is very well suited in adults, but still we are not using any fixed drug mixed insulin or even Rhizobag as well.